So next, we've got Florin Vadean, who's a colleague of mine from the Adult Social Care Policy Research Unit based at the University of Kent. And he's going to tell us about wage differentials and wage elasticities of labor supply for adult social care. So Florin, over to you.
Thanks, Jose Luis. I hope you can all see my screen.
Yes, we can.
So this work that I'm presenting is joint work with Steve Allen from PSSRU, University of Kent. The study is part of the NIHR policy research unit in adult social care. And we express our thanks to the funder, but also to Skills for Care for sharing with us the data used in this study and for the support provided. And also the usual disclaimer applies that the views expressed are entirely those of the authors. Adult social care in England is a quasi-market. So it is supplied by about 18,000 care providers providing care in about 39,000 establishments, and with about 85% of the workforce employed by independent providers. On the demand side, a substantial part of services is publicly funded and commissioned, with a downward pressure on tariffs paid by local councils due to budget constraints. And this may have also resulted in restrictions to wage competition between care providers and a large share of care workers being paid at minimum wage levels. There is a substantial literature assessing the effects of competition on prices and care quality, like, for example, for the English care home market, a study by Forder and Allen found that competition has negatively affected both prices and CQC quality ratings, with a negative effect on quality working through prices, meaning that greater competition has a negative effect on care fees, which reduces the provider's revenue and ultimately quality. Also, Allen and co-authors identified in a further study that competition mainly reduced the fees paid by self-funders and also reduced the fee gap between self-funders and publicly supported residents. Research on wage structure and labor market competition in adult social care has been more scarce. An exception is a study by Matching and Manning, in which they analyzed the care home market on England's south coast in 1992-93, so about 30 years ago, at the beginning of the marketization process in social care. The evidence they found, like, for example, very simple wage structure of either one or two different hourly wages in the majority of care homes, also that about 65% of the variation in wages was between care homes and only the remainder within care homes, and that the wage differences were not associated with higher productivity. These were all inconsistent with the competitive market theory and leading to the conclusion that care homes had a considerable discretion in setting wages due to labor market frictions. Considering the substantial marketization process of the adult social care sector since the early 1990s and the pressure on labor markets from both monopsonistic markets for social care services and minimum wage policy in the last years, the aim of this paper was to reassess wage differentials and evaluate the degree of competition in adult social care labor markets in England. And we derive wage elasticities of labor supply to the firm which is a metric for competition, using a dynamic monopsony model that assumes that labor supply is not perfectly elastic with respect to wages due to frictions in the labor market that reduce the workers' ability to move swiftly between jobs. In social care labor markets, a potential source of frictions would be that care workers derive motivation not only from pay and employment conditions, but also, and sometimes even more, from the care motive or the relationships staff build with their clients. The job separation rate is modeled as negatively related to wages, while the inflow of recruits positively related. And an important assumption is that in the steady state, the total job separations equal the inflow of recruits, and the wage elasticity of labor supply facing the firm can be then deduced as being -2 times the wage elasticity of job separation. This is a rather neat simplification, but is quite widely used in the labor economics literature. And a common approach to estimating the wage elasticities of job separation that is used in previous studies is from hazard or duration models. And an important problem in estimating wage elasticities of separation comes from the failure to adequately control for other relevant factors with omitted variables known from previous studies to bias wage elasticities towards zero. To account for this, we used, on the one hand, a large set of worker, job, employer, and labor market characteristics that were identified as important confounders in previous studies. And on the other hand, to control for unobserved heterogeneity, we used panel data estimators. So we used random effects or shared frailty models, but also more flexible estimator for binary settings, the so-called correlated random effects probit, which give within estimates similar to those from a fixed effects estimator. I think I'm skipping a page here. I'm not sure how to, yeah. So the data used is from the adult social care workforce dataset. It is the main source of social care workforce data in England, covering about 50% of the market. The analysis is based on 4 cuts from the dataset, October 2016 to 2019. Care establishments and workers are identified through unique permanent IDs and can be therefore traced over time to identify job separations. We included public, private, and voluntary establishments, and we focused on care homes with nursing, care homes without nursing, and domiciliary care. And we included workers employed under either permanent or temporary contract, age 16 to 64, and in a direct care role. And the final sample, after excluding observation with missing values, consisted of about 355,000 observations of about 211,000 job spells in 8,300 care establishments. The distribution of wages among direct care staff in the year 2019 is illustrated in this graph through box plots by care setting and sector. And we first noticed the quite substantial pay gap between direct care staff employed by public compared to independent providers. We also note the quite narrow distribution of wages, in particular in the private sector, with hourly wages in the 90th percentile being only 12% over the national living wage. And this narrow distribution can partly be explained by the rather large share of direct care staff paid at minimum wage level. To assess to what extent the wage differentials are explained by observed characteristics, we estimated wage equations, and we found that everything else being equal, by far the highest difference in wages was between sectors of employment. So in our model, with a full set of controls and accounting for unobserved heterogeneity, the wage differential between the private and the public sector was 19%, while between the voluntary and the public sector was 15%. When we look at the wage differentials between sectors in a bit more detail in the table at the bottom, through predicted wages, also by care setting and job role, we know that the differences were lower for care workers and higher for senior care workers, pointing to potential differences in rewards to experience between sectors. And indeed, when plotting predicted wages by experience and sector, we see that the predicted real wage difference over 30 years of work experience is very low in the private sector, less than 3%, somewhat higher in the voluntary sector, highest and more meaningful in the public sector at about 12%. Looking at the variation of wages between employers, we found that these to be quite high, around 66 to 70%. So these were lower when controlling for wage variation between local authorities, and when also restricting the sample to only independent providers employing more than 5 direct care workers, so allowing more variation within the establishments, but still high for what would be expected in a competitive labor market. Turning to estimates of wage elasticities of labor supply to the firm, without controlling for unobserved heterogeneity, wage elasticities of job separation were comparable to those found by a recent study on long-term care workforce in the US. Our estimated wage elasticities were, however, larger compared to those found previously for NHS nurses or for the UK economy as a whole. Our results further show that estimates without controlling for unobserved heterogeneity were downward biased, so closer to zero. The bias correction by random effects model was rather marginal. However, within estimates from correlated random effects probability models gave a substantial bias correction with estimated wage elasticities over twice as large for residential care and about 3 times larger for domiciliary care. We found wage elasticities to be relatively higher, so more labor market competition in the private sector. The evidence of higher labor market competition in the private versus the public and voluntary sector being more evident also when looking in panel B of the table, the bottom side of the table, at the more homogeneous senior care worker and care worker roles. In terms of geographic differences, we noted that the highest wage elasticities of labor supply to the firm were in the Midlands, in particular West Midlands, while for domiciliary care, these were highest in the Midlands and the South, in particular Eastern, Southeast and London. Regions that are in general related to higher supply of social care services. To sum up, we found substantial wage differences of the direct care staff between sectors that cannot be explained by observed factors. And this may be evidence that the downward pressure on care fees for services commissioned by local authorities from independent providers may have led to a downward pressure on wages. And combined with the increasing minimum wage levels, they have led to the rather compressed wage distribution in the private sector and poor rewards to skills and experience. So consistent with results of matching and manning, we also found evidence for the high variation of wages between care establishments and too low variation within care establishments, which is actually not compatible with the uniform market wages for workers of equal quality expected by the competitive labor market theory. With respect to wage elasticities of labor supplied to the firm, our results highlight the importance of controlling for unobserved heterogeneity to reduce omitted variable bias. We found wage elasticities of labor supplied to the firm in the region of 3 to 4 for both residential and domiciliary care settings. These were quite similar, of a similar magnitude to those found in quasi-experimental labor economic studies and also studies accounting for worker unobserved heterogeneity. These estimates suggest a only a moderate responsiveness of direct care staff to wage changes, but also a far from perfect competition in the social care labor market. In contrast to previous findings, we found more competition in the low wage, so lower wage and higher turnover private sector. So the higher labor market competition did not translate into higher staff wages. And we think that the low competition in social care labor markets could be due to this, what I already mentioned, the downward pressure on care fees by local authority commissioning and the minimum wage policy, which also reduces the care providers' margins and their capacity to compete for labor force using higher wages. This study focused on estimation of wage elasticities of labor supply facing the firm. The wage elasticity of labor supply facing the sector is another quite useful tool, mainly for assessing and to what extent, the extent to which labor supply to the sector can be improved by increasing wages. And we are focusing on that in a forthcoming study. As the adult social care workforce dataset in this dataset, we cannot identify separations to outside the sector, meaning to jobs outside the sector and also to non-employment. Our strategy to estimating wage elasticities of labor supply facing the sector is based on the fact that the wage elasticity of labor supply to the firm can be decomposed in a weighted sum of wage elasticities of recruitment from inside and outside the sector, and also wage elasticities of separation from inside and outside the sector. And following certain assumptions and some simplifications of weight, the wage elasticity of labor supply to the sector can be then expressed as a weighted difference between the overall wage elasticity of job separation from an employer and the wage elasticity of separation to other social care jobs, which we can then both estimate using the adult social care workforce dataset. The weights being based on the share of job separations which are to other social care jobs, which we have from skills for care estimates. So I will not go in further details here. I'm not sure how many of you are interested in so many technical details, but I just wanted to flag this work we are currently pursuing to those in the audience with more interested in these technical details and who have knowledge on wage elasticities and I would appreciate also any feedback on this approach, even after the webinar. Thank you very much. And
thank you very much, Florin. Again, we've got 9 minutes for questions, so please raise your hand in the digital fashion. So whilst people perhaps think about possible other questions, have you thought about trying to understand the relationship between the social care workforce market and the healthcare workforce market? Because, you know, quite a lot of people that leave social care sometimes might go, you know, one of the reasons they might leave is to go to work in the NHS, and the availability of NHS jobs might be quite different across the country, for example. Have you explored this at all?
I haven't personally explored this. So this have been explored. I saw recently a report by the Health Foundation. So they have looked then also into these differences, and also in the transition, so job transition between social care and the healthcare markets, but using different data sets. So with the adult social care workforce data set, you don't get the information on the destination of job leavers. So you see only in the sample kind of transition within the sector that are, so within employers in the sector that are captured in the sample. But for the rest, you do not know where exactly they go. So there are other studies, like I said, from the Health Foundation. There is also a study by John Forth and Alex Bryson. So John Forth from City, Alex Bryson from UCL, who looked at the adult population survey, and then also show quite nicely that in the health sector, so similar jobs, so healthcare assistants, they do have a much better wage progression in time compared to the social care sector.
Thank you very much. And the link to the Health Foundation work has just been posted on the chat. Thank you very much. Are there any other questions? Catherine Henderson.
Hi, just a kind of general, sorry, I'm Catherine Henderson, CPEC. Just wondering, a bit like the agricultural industry and prices paid to, you know, chicken farmers and that sort of thing, what the longer term implications are of paying a workforce not very much and paying them not very much for having 10 years experience versus one.
Sorry?
I think that was somebody who was not muted.
Okay, so it was not related to your comment.
Nope, that was someone else. Yeah. So that was my question, really, was what you know, what does it do? I mean, obviously with farmers, there seems to be a long-term, you know, they eventually do start to be driven out of the market. But I just wondered what happens in social care then.
Well, in social care, the quite obvious consequences of low wages are very high turnover. So the turnover in social care is, I think in general, over 30% per year for the certain jobs like care workers, which are the frontline staff, and also in the public, in the private sector where wages are much lower. This, I think they reach almost to 40% turnover, which can be quite detrimental to this, the social care services provided, as it disrupts continuity of care. And Steve Allen, my colleague, and myself show in a different study that this higher turnover and higher vacancies in the sector are related to lower CQC quality ratings in care homes. And yes, the other part that I suggested is also vacancies. So many providers struggle to find sufficient staff to fill in job roles that they have, and this seemed to have now exacerbated, after in the post pandemic.
Thank you very much, Florin. So I can't see any other hands. So obviously, you can contact Florin after the workshop if you've got any other comments or questions. But let's just move.